Hello, I'm Dr. Pamela Kushner, a clinical professor of medicine and director of the Kushner Wellness Center in Los Angeles, California. I am affiliated with the University of California Irvine Medical Center. Welcome to today's program. It's Clinical Conversations for Better Type 2 Diabetes Control, focus on GLP-1 Receptor Agonists. And joining me today, it's my privilege to have Dr. John Anderson, who's an internist and diabetes specialist from the First Clinic in Nashville, Tennessee. Welcome, John.
Hi, Pam. Thanks for having me.
No, a pleasure. The treatment of type 2 diabetes has shifted from a purely glucocentric approach to a more comprehensive cardiorenal metabolic strategy. This approach is very valuable because it emphasizes the importance of preventing cardiovascular and renal events and the improvements of metabolic aspects beyond glucose control, such as weight loss. In this program, we're going to discuss the role of GLP-1 RAs in the management of patients with type 2 diabetes, and particularly in those patients with cardiorenal metabolic disease, or CRM. John, in people who have cardiorenal metabolic disease, that makes them a more complex patient, obviously. When you have a patient who has those multiple conditions or even risk factors for multiple conditions, how do you prioritize treatment?
Well, Pam, it's really about the patient sitting in front of you. Of course, and we'll look at sort of this schematic. I mean, if patients are having urgent problems, in particular, current hypoglycemia or something like that, address the safety issues first, right? That's what we always do. And then it's sort of what's the priority for that patient and for you, because it really is shared decision making. Is this someone who's just had a stent and a bypass and you're really interested in cardiovascular risk reduction or mortality drivers? Is this someone whose A1C is so far away from baseline that the main goal is to get glycemia under control? Is this someone who has struggled with obesity and overweight so that their priority may not be the dysglycemia so much as, please, doctor, anything I can do to get this weight down, what can we do? Then there are other risk factors. There's someone with CKD and chronic kidney disease, heart failure. Do they have a reduced ejection fraction? Would a certain therapy be more important? And of course, it really never, almost ever, Pam, is in a silo. Almost all of these patients have a combination of these things. They have obesity. Their A1C is not under control. They may have an element of heart failure. So it's about prioritizing what do we want to do first? How do we want to proceed? What therapies do we want to pursue? What lifestyles do we want to pursue? And then setting up a game plan for follow-up, measuring success, and that type of thing. And I know you do this in your practice all the time as well.
Yeah, and I really do. And I think that center of this screen is really valuable because shared decision-making is critical in getting your patients to stay on therapy. And the first thing I do is I say, Rome wasn't built in a day. We're not going to do everything in one day. But we have these multiple medical problems. These are what the risk factors are. And I do try to use person direct language. So I don't just jump into this. I say, can we talk about some of these risk factors? Because people sometimes smoke and they go, I'm never quitting smoking. Or they're obese and they say, and they don't feel comfortable. They've been stigmatized their whole life and they're not recognizing that this is a chronic disease and that I'm comfortable talking about it. So I might say, one of these risk factors is the fact that you're overweight. Can we talk about that today?
Right.
But everybody has something that they want to do later in life, that they want to have that extra year or two of life or 10 years that they just expect. Maybe they want to travel around the world. Maybe they just want to play with their grandchildren. Maybe they want to just go hiking. And all of these things are going to require us giving them that better quality care. And I always think about the Steno trial that really followed patients for 13 years. And this was done 2008. So this is a long time ago. But they found that this intensive multifactorial approach to patients and looking at, as you mentioned, all these different risk factors and addressing them, which we do with hypertension, hyperlipidemia, we do it all the time, social issues. When we address these multiple issues, you're not only decreasing cardiovascular disease, but you're decreasing all-cause mortality. So I think it's really very valuable for our patients. So going forward, can you discuss a little bit of these cardiorenal effects of the newest anti-hyperglycemic agents?
Yes, let's look at the newest GLP-1 receptor agonists as well as the SGLT2 inhibitors. And we understand that these drugs were developed to lower glucose. but we have found just this myriad of benefits across these classes. So if we take this schematic you see here, and we look at A1C reduction, weight effects, MACE effects, that's major adverse cardiovascular events, that's non-fatal MI, non-fatal stroke, and cardiovascular death, heart failure effects, slowing the progression of chronic kidney disease, and then hypoglycemia risk, we see that GLP-1 receptor agonists, the most popular being semaglutide, both injectable as well as oral, have an A1C reduction that's high to very high, very potent agents, right? The weight effects are anywhere between intermediate and very high. They've become very popular for their non-glycemic effects, right? And then the cardiovascular outcomes trials have been done in injectable semaglutide as well as liraglutide and dulaglutide have shown benefits in 3-point MACE. Now, the original Pioneer 6 with oral semaglutide showed a benefit, but the study was never powered, right, to have a cardiovascular benefit. Well, the SOUL trial, SOUL, was just completed, and we found that oral semaglutide also has a benefit for cardiovascular risk. And then these seem to have some benefit in preserved ejection fraction heart failure, and they have been shown to reduce progression of CKD, particularly driven by a reduction in albuminuria. And again, we've got semaglutide, liraglutide, dulaglutide, all showing benefit. And of course, on the far right, none of these agents tends to cause hypoglycemia by themselves because they stimulate the pancreas to produce insulin in a glucose-dependent fashion, which means glucose goes up, they turn the jets on. When it goes down, they tend to mitigate that effect. The next one that's one of the newer agents that we've had around for about 2.5 years in the United States marketplace is the dual GIP and GLP-1 receptor agonist, tirzepatide. Very high A1C reductions, probably the best of the weight reductions, very high. And then we just saw the SURPASS cardiovascular outcomes trial show that in comparison to dulaglutide, in terms of 3-point MACE, it was non-inferior. We know that dulaglutide is approved for patients with type 2 diabetes and established cardiovascular disease and high risk to reduce cardiovascular outcomes. Well, this was actually better than the dulaglutide, but it didn't quite reach superiority, so it meant non-inferiority. And we'll wait and see what the FDA says about that for cardiovascular risk reduction. Heart failure effects under investigation, progression of CKD, we see that same reduction in albuminuria, but again, we'll have to wait for those trials to be done. And of course, then the bottom, there's SGLT2 inhibitors, which of course are oral agents. A1C reduction is not quite as potent, but very nice. You do get a benefit of weight loss, although not that robust weight loss that we see with GLP-1s and dual agonists. And of course, the MACE effects were positive for canagliflozin and empagliflozin. Now, remember when EMPA-REG first came out in 2015, it sort of blew the scientific community away, especially with a 38% reduction in cardiovascular death. And then all of them seem to have some heart failure benefits. All of them seem to have some decrease in progression of CAD. So when we had that first slide, we're talking about how to make decisions for our patients. Again, it makes our job a little more complex, but isn't it great for patients that we have so much more to offer them than just glycemic lowering?
No, it's really great. And it's interesting you mentioned the SOUL trial because many clinicians may not be familiar with that, which decreases the risk, the actual quality of life of patients who have PAD, and they're able to move more. And we've had nothing for PAD. And remember that PAD, I always think of as the canary in the coal mine for CAD. So that's they did get that benefit. So the other point is that you want to remind people that class effect doesn't matter. So you may want to choose agents that have a proven benefit. That would be valuable. And the latest one is is approved in patients without diabetes for semaglutide, which is the MASLD, and that they have an indication for helping liver disease. And some people are saying, well, gosh, this is just because they lost weight. Well, we don't know it's just because they lost weight. We really just don't understand, but we're grateful that these are so effective. So please give me some evidence-based guidelines about the use of GLP-1 RAs in patients with type 2 diabetes for the audience.
Happy to, Pam. So if we talk about GLP-1 receptor agonists, we look at the American Diabetes Standards of Care. They're updated every year. This is the new 2025 guidelines. GLP-1 receptor agonists are indicated for patients who have established or high risk for ASCVD, for both the glucose control, as we talked about, and for cardiovascular risk reduction. With symptomatic heart failure with preserved ejection fraction and obesity for glucose control and heart failure-related symptoms. And then if you have CKD with an eGFR between 20 and 60 mLs per minute and or albuminuria, they're indicated for glucose control, slowing CKD progression and cardiovascular event reduction. And with advanced CKD, they're indicated for glucose control and CV event reduction. And it's interesting to point out, Pam, that these do not have a lower EGFR threshold for their use. They are broken down and cleaved by protease enzymes. So you can use this in patients with advanced CKD, even end-stage renal disease, and in patients who have hepatic insufficiency. And for those patients, I mean, there's been so few agents that we have that are either effective or even approved for use. And then if we look at SGLT2 inhibitors, they're approved with CKD between eGFRs of 20 and 60 for glucose control, slowing CKD progression, as well as CV event reduction. And then it doesn't matter if you have preserved or not preserved heart failure, they're indicated for glycemic management and for heart failure hospitalization reduction. And the numbers are pretty big in the 30+% category. So it's not a minimal benefit. And then for patients with established or high risk ASCVD, for both the glycemic management, again, very much like the GLP-1 receptor agonists, as well as cardiovascular risk reduction. And then you can consider both looking at individual drug effects for CRM comorbidities, CV, kidney, weight, hypoglycemia risk, safety and tolerability, cost and access. And again, it goes back to what we talked about at the very beginning. It's about shared decision-making and having that conversation with the patient who's in the room with you.
That's right. And what type of patients or clinical scenarios are you using the combination of GLP-1 and SGLT2 inhibitors, John?
That's great. So the patients who need more glycemic lowering, right? I mean, maybe the GLP-1 or the dual agonist didn't get them to where they were, or maybe I started an SGLT2 inhibitor with or without metformin. And they come in and they go, "Ooh, that A1C's up. We're going to need a fairly potent agent. A DPP-4 inhibitor is not going to get you there. A TZD is not going to get you there." So we got glycemic lowering. But then again, maybe they also have obesity and overweight that needs to be addressed. Maybe we need to look at cardiovascular risk. But remember that these clinical outcomes, these are additive clinical benefits for each individual versus each individual agent alone. For example, let's look at weight reductions. If you have an SGLT2 inhibitor and a GLP-1 receptor agonist, remember that the weight reductions that you see are by two entirely different mechanisms, and they can be complementary. Also, GLP-1 receptor. Go ahead. Yeah.
We only have a few minutes left, John, so I'm cutting you off. Tell me
Okay.
what I think people can see the challenges on the screen, but one of the points that I also wanted to mention is if you use a GLP-1 with an SGLT2, you can start that GLP-1 on a low dose, because you have to start on a low dose anyway for side effects. And then by the time a month goes by, you can be increasing it and follow what the prescription says, what it says to do. Each one is different, but that way you have that SGLT2 inhibitor on board. So moving along, John, long-term adherence is an issue with all these drugs, we know, and persistence. So what can you say for guidance for clinicians to address some of the challenges to get the patients on the drug?
Well, the main thing I see for adherence and persistence is cost. It used to be that patients in a Medicare plan would get through what we'd call the donut hole, and they would not be able to afford the medication during the back half of the year. We would also see that sometimes they didn't tolerate the medication, in which case we might switch agents. We would also see this in some cases, there's always a non-responder. Maybe they stopped because they didn't respond and didn't see that efficacy they expected. Sometimes we didn't meet the patient expectations. So, there's a lot of reasons that can do that. And so, Pam, you and I do this all the time,
We do.
education, make sure the patient is buying into what you want to do. Talk about what your expectations are, follow up on your plan periodically. Don't just say, "I'll see you in 6 months." Have that conversation back and forth. Titrate dosing. If you get to a titrated dose that the patient doesn't tolerate, you can always back down.
Yep.
We can use telehealth. We can use telehealth tools. I got rural patients who may not want to drive into Nashville, Tennessee. And then our pharmacists, our CDCES, all that team that can help keep the patient motivated. I think we underutilize all of the time.
100%, John, especially the CDs, sending someone to a nutritionist, a certified diabetes education specialist. That value cannot be overestimated. So I'm going to give you a summary then. The summary basically that my take-home points are: shared decision-making is critical. You got to get that patient's buy-in. You have to find out what's important to that patient. It's part of motivational interviewing. And I think that nobody is better than primary care at doing this, because we're with that patient from the beginning to the end. And we want to make the end further along. And multidisciplinary, multifactorial, multifaceted care is the way it is. We are really blessed to be living in a day and age where heart failure, chronic kidney disease, cardiovascular death, all-cause mortality with effective cardiorenal metabolic treatment can be really maximized to the patient's benefit to delay these or to at least slow the onset of them. And then these proven therapies are evidence-based. If you don't feel comfortable with it, refer them to somebody who can give you some further guidance, or you can watch the metabolic treatment challenge that we will be talking about in just a second. And mortality and CV outcomes by intensive CRM treatment is a reality today. And thank you all for what you do. Remind yourself daily that you make a difference. And John, thank you so much for joining me today. And if you're looking for more information on this subject, please go to medscape.org, and you can go to a metabolic treatment challenge. Can you best your peers? To repeat it, it's a metabolic treatment challenge. Can you best your peers? This is a more detailed, accredited, case-based program that's available, and we welcome you to join. Best wishes.